I'm going to talk about interpreting single antigen bead, and I hope at the end of the talk, there'll be probably 20 to 25 minutes for questions as well. So what am I going to focus on? So first, we'll do a little bit of terminology clarification, so everyone is on the same page in terms of how we talk about each of these technologies, as well as each of these acronyms that get thrown around everywhere. We'll talk about how the single antigen bead is performed, what it tells and what it does not tell, how to assess for the donor specific antibodies by combining the single antigen bead and the donor typing. And then at the end, we'll do multiple cases of how do you combine the CDC crossmatch, the flow crossmatch, and the single antigen bead, and your interpretation for the donor specific antibodies to come up with a comprehensive immunological risk profile to then decide how to proceed for transplant. So first, terminology. So SAB is the single antigen bead test. If it is positive, what you know is that there are anti-HLA antibodies. What you don't know is, are they donor specific or are they not, just by the single antigen bead test. So then to know whether there are donor specific antibodies, or DSA as we like to call them, what you need is to look and combine manually the single antigen bead report as well as the donor typing and look at it together to figure out which are the donor specific antibodies and which are anti-HLA antibodies, but they're not against the donor. And then there is this confusion that gets created by a test called the DSA lysate. It is also called the Luminex crossmatch. It is a completely separate test in which the donor cells are lysed, combined with the plate, and then you test with antibodies. And this is a test that I'm not going to be talking about in the talk today, but we can talk in the question answer session if someone wants. But it's a test that I do not recommend for anyone to do. Okay, so now let's talk about the single antigen bead. So the single antigen bead is a collection of bead made by two different manufacturers. Each one has their own bead panel. But at the crux of it are these beads, which are each of a different dye and a different color. And then they get coated, each one gets coated by a specific antigenic allele. So like A0101 is coated on this blue bead, and then A0201 on this red bead, and then A0202 on this green bead. So what you end up having is that each single antigen bead is coated with one single antigen and a specific allele. So it's a specific 4-digit or 6-digit allele that is coated on these beads. So now what you do is you take these beads and you incubate it with the serum of the recipient or the potential recipient, which will have lots of different antibodies, and they will bind to an antigen if they're specifically against that antigen. So in this case, there is an antibody that is against the A0101, which is going to bind to it, and all these other antibodies that are floating around will be there. But then in the next step, they'll get washed away. So the next step is washing, and so all these other antibodies get washed away, except that one antibody that is stuck to A0101. Then you come in with an anti-IgG, which is tagged with a fluorescent tag. Could be FITC, but could be any other fluorescent tag that you want. So now all these anti-IgGs are floating around, but the one that is going to stick is to the one that has an IgG antibody stuck to the bead. So which is again the A0101 antigen that has an antibody stuck to it, which is an IgG antibody. And so now there is this FITC that is stuck to it. Then you wash again. So all these other antibodies with the fluorescent tag go away, and you get left with just this one antibody. Then you go into the flow cytometer and you put these beads, and they will now in the flow cytometer go one bead at a time. So this first bead has gone in. It was the 0202 bead, and it has a mean fluorescent, it has a fluorescent intensity of 100, this one, and then the mean, which comes from reading at least 100 beads. So the flow in the bead panel, there'll be 100 to 150 to maybe even 200 beads for each specific antigenic allele. So like A0202 would have like 150 beads, and the flow cytometer will try to capture at least 100 of these events for A0202 and then give you the mean intensity. So the mean intensity for this is 100, and then you have this curve that comes up at the end of the results. So then the next one bead that goes through is the one that has the antibody, IgG antibody with the FITC connected to it. And so therefore the fluorescent intensity is much higher. And in this one, the fluorescent intensity is 3000. It counted 100 of these beads, and the mean of that intensity was 4000. Then the next one goes in, and that's negative. So then you get a report like this. So this is the single antigen bead report, where you have the 0101, which is at 4000. All these other ones are negative, and then you have 1101 and 1102, which are positive at 5500 and 4800, with the other twos as negative. So based on this, what you can say is that these are anti-HLA antibodies against A0101, A1101, and 1102. So there are these three anti-HLA antibodies. Are they donor specific or not? For that, you need to look at the donor typing. So now let's look at the donor and recipient typing. So the donor typing is A0202 and A1101, while the recipient typing is A0301 and A2301. One of the key things and key concepts in HLA is that you cannot make self anti-HLA antibodies. So this works as a beautiful internal control, because the single antigen bead report will also have the HLA antigens of the recipient themselves. And so now these red arrows are the HLA antigens of the recipient, which it should be negative. If they're positive, then it means that there is a very high background, or there is a sample or technique error. So you need to probably rerun your sample. Then you look at the donor typing. So the black arrows are for the donor typing. And so now you know that there is an 1101 antibody, which is donor specific. So the A11 antibodies are donor specific, while the A01 is an anti-HLA antibody, but it is not against the donor. So it is not a donor specific antibody. So now we've gone through the terminology as well as how do you come up with the single antigen bead report and come up with donor specific antibodies. So the conclusion from this single antigen bead with the donor typing would be the A1101 with an MFI of 5500 is a donor specific antibody, while the A0101 is only an anti-HLA antibody, but not a DSA. So summarizing so far, so what we have is the single antigen bead. On the left, we have all these beads that have these single antigens on them. We combine them with the sera. If the sera has antibodies, it will stick to that particular bead. We go in with the anti-IgG with the fluorescent tag. We'll read that with the laser, and then we know what the fluorescent is. So at the end of it, what we know is that there is an IgG anti-HLA antibody against a specific antigen. With the donor typing, we can identify if there are donor specificity. What we don't know is whether these antibodies bind complement, what MFI value or MFI cutoff is really significant. And that's something that each lab will have to determine, and each lab will have, and the transplant program will have to have a judgment of what they want to be considered significant and how they want to use it for their judgment. And we'll talk a little bit about it through the cases that we do. And the clinical significance needs the CDC crossmatch and the flow crossmatch put together to kind of make that symphony that we're going to talk about over the next few minutes. So why is it a semi-quantitative test and not a truly quantitative test? So this is a paper published in 2013. And on the left is the variability. So this is coefficient of variability in the MFI. And this is percentages up to 100%. And this is what they did was they took 10 kits from the 2 manufacturers that make it. And this was evaluated at 7 labs with 20 reference serum samples that were taken. And what they were looking for was intra-lab and inter-lab variability. So when they gave the same lot to all 7 labs, same lot to all 7 labs from the 2 different companies. So SA2 is company 2, SA1 is company 1, and there are these 2 different lots that they did, and they gave them specific standard operating procedures. So the white bar is when they had their own procedures. These boxes with the lines are the ones that are with the standard operating procedures that were made specifically for this study. So that decreased the variability from about 50% from whatever the lab had their standard protocols to the protocols that were standardized across all the labs to about 20-25%. But no matter what they did and how much they tried, there is a 20% variability that is going to be part and parcel of this test. The bottom right corner is that this 20% variability is similar no matter what the MFI, from 0 to 500, 500 to 1,000, all the way up to 25,000. This variability is in the 20-25% range. So even with a very comprehensive and prescribed standard operating procedure, there is a variability of 20%, which is why there may be labs that will not give you an MFI value, may only say positive, negative, or the labs will tell you that don't use this MFI as a fixed value, because even if you run the same sample in the same lab with the same kit a second time over, an 8,000 might become 10,000, or a 10,000 might become a 12,000, because there's a 20% variability that is inherent in this test. Okay. So now we'll come back to how do you put all of them together to create the symphony. And so what we will go over are a combination, possible combinations that you can have. So we have the CDC crossmatch, we have the flow crossmatch, we have the single antigen bead, and then we have the donor specific antibody, which is the single antigen bead combined with the typing that you have. And then we'll talk about what plans should you have for each possible combination. So CDC can be positive, everything else negative. CDC negative, flow positive, everything else negative. Everything is positive. The single antigen bead is positive, but there is no donor specific antibody, or there is a single antigen bead with the donor specific antibody, but the cross matches are negative. So we'll talk about each of these cases one by one. So let's start with the top one. So you have a 35-year-old female with kidney disease from lupus. Her mother comes as a donor. So she has no previous sensitization history, isn't married, and so doesn't have any kids, and has a CDC crossmatch, which is positive. Flow crossmatch is negative. You do the single antigen bead class 1 and class 2, and there are no anti-HLA antibodies. So why is the CDC crossmatch turning positive? So that is because lupus patients can have autoantibodies, and that autoantibody is what is turning the CDC crossmatch positive. So you do an auto CDC crossmatch that is positive. This can also happen with HIV patients or other patients that have high hypergammaglobulinemia. So they can have these broad spectrum antibodies that can cross react as well. So you can proceed for a transplant with your usual immunosuppression, and the outcome is good. So this is one of our cases with no post-transplant rejection with the usual immunosuppression. So now let's talk about our second case, in which you have a CDC crossmatch negative and a flow, which is B cell, which is positive. So again, a 30-year-old male with end-stage disease from Alport, mother as a donor, no history of any sensitization, CDC crossmatch is negative, flow crossmatch is B cell positive, and again, the single antigen beads are negative. So you can look at this. So all of them are below 1,000. The maximum one is about 600. So this is class 1. Class 2, again, all less than 1,000. And so the single antigen bead is completely negative. So there is something called a sticky B cell, in which you can have a B cell that will have some non-HLA antibodies that will stick to it, and that can turn your B cell flow to be positive. So again, if your single antigen bead is negative, you can move forward like a regular transplant with no extra immunosuppression, and your outcomes will be good. So now let's go to a combination of CDC, flow, as well as antibodies that are positive. So we have a 38-year-old female who has multiple sensitization history with multiple transfusions, 2 pregnancies, and she's had multiple cross matches that she's had done with her father, mother, husband, uncle, and all of the cross matches have been negative. She's gone to 10 different transplant programs, and she kind of comes to you as a last resort as well. You look at her single antigen bead, 1 and 2, there are multiple strong antibodies. Almost all the A and the DQs are positive. And so what do you counsel her and how do you move forward for her? So the best situation in this is to look for a sibling who is a 2 haplo matched. So we asked her to look for us to go back to her siblings, even if they're blood group incompatible, because she was blood group O, that we should just go ahead and do a CDC flow cross match. Don't do any other testing. Don't do any other typing. Just do a CDC flow cross match as the first test. If the CDC and flow are negative, then we'll work the brother up. Her brother turned out to be 2 haplo matched, cross match negative, but was blood group B. And so we ended up doing an ABO incompatible transplant. Post-transplant, about at year 1 and at the end of year 2, she had a couple of serious infections with the pneumonia and transplant pyelonephritis, but recovered from both, and her current creatinine is 0.8 at 3 years. Her current immunosuppression is pretty low, with a TAC level running around 3, MMF only 180 milligrams daily, and a PRED of 5. Because she's 2 haplo matched, her immunosuppression requirement is pretty low. So what are the options for sensitized recipients? So the first option is to see if they can find an alternative donor who is especially siblings where there is a possibility of being 2 haplo matched. Even if they're ABO incompatible, the risk of an HLA incompatible will be much higher than an ABO incompatible. So that is something that you should explore. If there is no donor like that, a swap or as a last desensitization can also be considered. And we'll talk a little bit about the risks of desensitization and which kind of patients you shouldn't proceed for desensitization and which you can discuss with the patient and proceed. So let's look at a few slides on outcomes of desensitization. So this is the classic Montgomery paper from NEJM in 2011, in which the blue line is patients who underwent desensitization, and what we're looking at is mortality, and the mortality at around 5 years to 6 years and 7 years is around 80% survival. Compared to if they stay on dialysis, which is the green line, and their survival is only 30%. If they continued on dialysis, but they did have the option of getting a transplant, and some of them got transplanted as well, the survival is about 49%. So if you desensitize patients and get them to a transplant, even with the risks that we'll talk about down the road in the next few slides, their survival is better. So what are the graft loss? And that is Dori Segiv paper from 2014, where he combined the outcomes from 22 programs that were doing desensitization and looked at the percentage graft loss at 5 years. And so the top yellow line dotted is those who were CDC crossmatch positive. So at 5 years, 40% graft loss. So those who had a flow crossmatch positive, but CDC was negative is the second line, which is about 30% at 5-year graft loss. Third is where there were HLA antibodies, but both the CDC and the flow crossmatch were negative, is about 20%. And then those who were HLA compatible is about 17%. And so this is something that you can think about and talk to the patients about the outcomes. And again, if you look at the CDC crossmatch, the majority graft losses are within the first few months. So within the first 2-3 months is the main 10% difference, and then the slopes seem to be not that different. So the strength of the antibody does correlate with the crossmatch. So if you have a CDC crossmatch which is positive, usually the antibodies will be about 20 to 25,000, and this is DSA 1, 2, or the combination. If you have a flow crossmatch with a mean channel shift of more than 300, you're talking antibodies in the 10 to 20,000 range. If you have a low flow crossmatch positive, you're in the 4 to 10,000 range. And if your crossmatch is negative, you're usually below 1,000 to 5,000. So that's kind of what the antibodies are. But again, each lab is going to have some variability around that. The strength of the donor-specific antibody also predicts antibody rejection. So if you have a donor-specific antibody before the transplant, so again, these are before transplant studies, that is more than 10,000, you have about 50% antibody rejection rate within the first 90 days. So the first column is 90 days, and majority rejections, antibody rejections are happening within the first 45, 50 days. And that's the majority of your antibody rejections. And you're going to have about 40 to 50% of those. If your donor-specific antibody is between 5 to 10,000 or less than 5,000, in this study, it seemed about the same with 20% rejections. And again, majority of them are going to be within the first 3 months. If your donor-specific antibody is negative, you're barely any antibody rejections at all. So my take home is that with this level of antibody rejection and graft loss, I would not want to desensitize patients who are CDC positive, flow positive with a mean channel shift more than 300, a DSA that is single more than 10,000, or multiple DSAs that are more than 5,000. So what counseling would I do for the patient if I am planning to desensitize them? So the first thing I will tell them that the mortality is better with a transplant than without a transplant. That's the benefit. And that's what the Montgomery paper shows clearly. However, the graft outcome is not going to be the same as other people who don't have antibody. So that is something that they do need to know, that no matter whether it is just a donor-specific antibody with cross-match is negative, or CDC or flow cross-match positivity, the outcome is not going to be as good as the others. The risk of antibody rejection, depending on the cross-match which is positive and the level of antibody, is going to be somewhere in the 20 to 40% range in the first year, and predominantly this is going to be in the first 3 months. Each antibody rejection is going to cost somewhere in the 6 to 8 lakh in terms of treatment, biopsy, plasmapheresis, IVIG, some plus minus rituximab, single antigen bead monitoring. And so the patient and their family should be aware and ready for this kind of investment to move forward with a desensitization transplant. Because if you're going to go forward with this high risk transplant and you have a 20 to 40% risk of having a rejection, they should be able to manage this, because otherwise they're better off not proceeding with this. And if they do get an antibody rejection, the graft survival is lower than what it would be than if they don't have a rejection. So now let's look at a few cases as well that we've had. So 36-year-old female with dialysis from crescentic IgA, has mother as a potential donor. She has multiple blood transfusions in one pregnancy. Her B cell flow is weak positive with the CDC negative, and the donor and recipient typing is there. She has multiple anti-HLA antibodies with the highest of 11,000. She has low-level anti-HLA antibodies for class 2, highest of 3,000. We look at the donor typing. There are 2 antibodies that are against the donor, 2,000 against 1101 and 2,500 against DRB03. So even though her overall anti-HLA profile is much, much higher, she is currently lucky because of the 3/6 match that she has. Well, the antibody titers are lower. So what we ended up doing is we transplanted with ATG 4.5 milligrams with 1 plex and IVIG, and her overall immunosuppression was kept higher for about the first 3 to 6 months. And she's doing well now at 1.5 years with a creatinine of about 1. So now I do want to share a case that initially we were not doing single antigen bead in all our cases. And so what happens when you don't do single antigen bead? So this is a patient who had multiple pregnancies. Her CDC crossmatch and flow crossmatch were negative. The donor was her husband's brother, and we didn't do the single antigen bead. So the husband's brother turned out to be 2 haplo match to her husband. And at day 7, she had an antibody rejection. Her previous sample for the cross match, they still had some serum left. So we ran the single antigen bead on both the pre and the post. The pre titer was about 5,000 and the post titer was about 8,000, the highest MFI. And so one of the take homes is that single antigen bead is essential, especially for patients who have high risk by history of sensitization, or the relationship that you're transplanting is going to be high risk, like a child to a mother, or a husband to a wife, or a husband's brother or husband's family to a wife. So what ended up happening, this is the post one. So she had a DQB0201, which is a class 2 antibody at about 8,000, and a 2,600 for a DQB03. So we treated her with plasmapheresis, ATG, and she luckily responded. Even though her creatinine peaked at around 4.5, it came down to about 1, and her immunosuppression has been kept higher, and she continues at around 2 years still to have a creatinine of 1. So now let's look at a situation where your single antigen bead is positive, but the donor-specific antibody is negative. So 45-year-old male with dialysis, with wife as a potential donor, has a CDC Flow crossmatch negative, multiple anti-HLA antibodies with the highest of 8,000 for class 1, and multiple anti-HLA antibodies with the highest of 4,000 for class 2. But there are no donor-specific antibodies. So in this kind of situation, you know that he is sensitized, but at present his risk is not higher in terms of the acute or hyperacute rejections. So we transplanted him with extra ATG. We usually give 3 mg per kilogram. So we gave him 4.5 mg per kilogram and kept his overall immunosuppression higher. And he's doing well at 1 year with a creatinine of 1.5. So now let's look at the last situation where you have a single antigen bead which is positive with the donor-specific antibody that is positive as well. So this is a donor where the donor-specific antibody is against A6801. There are lots of other anti-HLA antibodies on the top, and in the B antigen, it's against B1801. So those are the DSAs, A6801 and B1801. So there were also class 2 antibodies. So, and that's something kind of to note as well, that when you do get your single antigen beads, there may be other antigens that they have antibodies to. And so you may need additional typing like HLA-C typing, DQ or DP. And as we needed for this patient, so DR51 and DR53 that are there are usually not typed in our HLA typing. So you would need to ask for DR51, 52, 53, which are also called DRB345. So that additional typing may also be needed. In this patient, actually none of those were donor-specific antibodies with the additional typing that we got. And so we, again, did the transplant with the extra ATG because of his overall sensitization, and kept his overall immunosuppression higher. He's now doing well at 2 years with a creatinine of 1. So now let's summarize as to what kind of our approach can be. So if your CDC is positive, but everything else is negative, the things to look for are an autoantibody like lupus and HIV, IgM antibodies, so you should treat them, investigate, but usually this is going to be a technical issue with the CDC and it's a non-HLA antibody. So you should be able to go ahead and do the transplant. If you have a flow crossmatch which is positive with single antigen bead which is negative and there are no donor-specific antibodies, usually it's a sticky B-cell transplant, a B-cell flow, and you can move forward with the transplant with no extra immunosuppression. If everything is positive, CDC, flow, single antigen bead, and these are due to donor-specific antibodies, the best thing would be an alternate donor, especially a 2-haplo matched. A swap can be considered. However, if there are so many HLA antibodies, finding a match for them is going to be hard. They can go on the cadaver list, but again, finding someone on the cadaver list that they don't have antibodies to is going to be very hard as well. And desensitization can be done. Again, you would have to see what the profile is, how high are the antibodies, and what the risk tolerance and capability for the family is as well as for the transplant program. If the single antigen bead is positive, but there are no donor-specific antibodies, then you can go ahead and do the transplant. If the single antigen bead is positive as well as there are donor-specific antibodies, again, you go to the list of whether it is something you want to desensitize, swap, alternate donor, or cadaver list. And again, it will have to be a discussion with the family and the patient to come up with what the right combination is for them. So take-home messages, single antigen bead test adds crucial information in evaluating the immunological risk pre-transplant. A combination of CDC Flow and single antigen bead currently, in my mind, gives the best and most comprehensive immunological risk assessment for a donor recipient pair. Assessing the single antigen bead report requires knowledge of the donor typing to know whether they are donor specific or not. Be aware of the risk profile, and then in concert with the patient and family, make a careful choice of what the best option is available. I have a longer talk on YouTube that is already there that was done through Dr. Jha's Kern Foundation. And so that is up there as well if someone would like to go through